Hi, this is Elliot Fishman, and welcome to YouTube Live. We're in YouTube Studios. Happy to be here. It's Thursday, September 29th. It's hard to believe that the month is ending tomorrow, and we're going to be in October. Um, we wish all of our friends in Florida, particularly those on the West Coast, but I guess East Coast or anyone in the South, we hope you're doing okay. I saw that the horrendous flooding and the hurricane and everything else. I hope everybody is safe. Just a true natural disaster. But I hope everybody's doing okay and that hopefully electricity will be coming on soon and you can then watch us. I know that's the first thing on your mind, but I hope everyone is doing okay. And we do give everyone our best and hope in a very difficult situation. So let me say that first and foremost. And then for the rest of us, it's October. October is almost pre-RSNA time. I think it's been a pleasant fall so far, and hopefully it will continue. Again, I think a lot of people will be affected by the hurricane. I don't watch much TV. I don't watch any TV, but I don't watch the news all that much on these hurricane things. But I know it's going across Florida, through Orlando to the East Coast, and I know places like South Carolina will have issues. So we wish all those people well as well. Now, the talk today is supposed to be on liver tumors, benign liver tumors. Now, I will first of all say that a very important topic. If you go to CTisus, the website, lots of lectures on liver tumors, benign, malignant, inflammatory, and everything in between. There's also thousands of cases in the teaching file of tumors, benign and malignant, inflammatory disease, all sorts of things, and lots of text. So everything is there to look at. So it's kind of interesting giving a talk, telling you what to look for without showing you any images is indeed a challenge, but that's what I'm going to try to do. So let's talk about benign liver lesions. They're very common, and the most common is a cyst. Probably, if you look hard, good thin section CT, 7 to 10% of patients have cysts. They can be tiny cysts, few millimeters, can be larger cysts. The biggest challenge with cysts sometimes is they're really small and it's hard to get a good feel for them. And then the patient has a known colon cancer, for example, and people say indeterminate liver lesion, can't rule out metastasis. Obviously, you say, well, it's so small. Of course, a 20 centimeter met was once 2 millimeters. So it's always going to be a challenge. And again, I think you can't get around the fact when lesions are way too small, it's really hard to say anything about them worthwhile. And that's true with CT, it's true with MR, it's true with ultrasound, and it's true with PET. Okay, so let's start thinking about benign lesions. We said cysts, water density, sharply marginated, no thickened wall, no enhancement, maybe a septation, but rare. If you talk about a cyst and the wall's thickened, then you got to say, could this be an infected cyst? Could this be an abscess? Could this be necrotic metastasis, like cystic lesions from a GIST tumor, cystic lesions from melanoma? Could this be an infected hematoma? Again, benign things you think about, but you need to be comfortable with them. So a cyst to me, water density, no peripheral enhancement, no definable wall. Now, it is true, yes, that if you have a cyst, it can compress adjacent parenchyma if it gets large enough, but there's no mass effect. If there's vessels nearby and if something's big enough, it's going to displace vessels, but it's going to stretch, not invade them, not compress them per se, but stretch. So that becomes very, very important. When I think about cysts, as I mentioned, differential, cystic lesions, cystic mets, abscesses, biomas. Now, a bioloma and a cyst can look pretty similar at times, particularly if it's not an acute bioloma or an old hematoma, but most of the time you have some history. Biomas are related to trauma, surgery, obstruction. It's not just something you find when you're looking for a renal stone. So that makes it a little bit easier there as well. Now, with cysts, I feel comfortable making the call. Again, if the patient has malignancy and something's really small, you could say too small to evaluate, but I will even go if it looks like a cyst, I'll say it looks like a cyst, just follow it. PET CT can be done sometimes, MR can be done in difficult cases, but again, you're not going to pursue every little cyst with an MR or a PET scan or anything else because you're not really going to get answers and you're going to raise the cost of care. You can follow things as well. Now, in terms of protocols, let me take one step back. We used to do non-contrast scans, but we haven't done that in a million years. Usually we don't do delayed scans. Occasionally we will, sometimes cholangio versus hepatoma. Cholangios get brighter with time. Occasionally on rule out hepatoma and a cirrhotic liver, where it is a challenge. Some people will say to go at about 3 or 4 minutes after injection to take a look and see if you see anything else. So that might not be totally unreasonable, and we are doing that lately. Typically, what we'll do for liver lesions to detect as well as classify will be 2 phases, arterial around 30 seconds and venous around 70 seconds post-injection. Ideally, injection is about 100 to 120 cc's of contrast, injected 5 cc's a second. Okay, that's pretty cool, pretty straightforward. Thin section CT, necessary. Coronals and sagittal, necessary. I do like 3D imaging. I think in the liver, volume rendering is ideal, but if you don't do anything fancy, just do MIP. And MIP can show you the vessels, and often the vessels stretch, the regularity of vessels, invasion of vessels, potential of pseudoaneurysms, lots of cool things. When we think about benign lesions, I mentioned cysts. The second most common thing is hemangioma. Hemangiomas can occur in 7% of the population, often small, but they can be very large. Giant hemangiomas mean 5 cm or better. What you see is peripheral puddling. When you inject contrast, there's puddling around the edge of the lesion. The lesion fills in peripheral to central over time. That's the classic appearance of hemangioma. In the old days of CT in the 80s and 90s, you would follow these lesions until they filled it in their entirety. Now we know when you see that puddling, it's hemangioma. We'll get 1 delayed scan or venous scan, or maybe at times just a 3 or 4 minute scan, and you'll see the peripheral fill in. We used to say it had to fill in its entirety. Then we realized that you often have scarring in the center of the lesion, and so things are not going to fill in their entirety and still are hemangiomas. But as Mike Federley showed me a long time ago, it's that first scan, be it 30 seconds or a minute, which shows that puddling around the outside of the lesion that gives you the diagnosis of hemangioma. People will say, well, what about a very vascular tumor like metastatic angiosarcoma or metastatic neuroendocrine tumor? They're vascular, they can be necrotic, they don't have that nice puddling around the outside. You can have Mets with rim enhancement, but that's not puddling, that's sort of starry night type appearance you get with hemangiomas. Now the next thing is focal nodular hyperplasia. That's always benign. The lesions are vascular, homogeneous, but with a central scar commonly. But when they enhance, they're vascular, but only as vascular as the IVC, not as vascular as the aorta. So that's an important finding. Vascular lesion, no underlying cirrhosis, only as bright as the IVC, has often a small feeding vessel or even a larger feeding vessel going centrally. That's going to be the definition of focal nodular hyperplasia. Now, as I mentioned, FNHs are benign lesions. They're leave alone. They're typically solitary, but they can be multiple. A bit more common in women, a bit more common in younger patients, but at times can be challenging. Usually the question is FNH versus hepatic adenoma. Hepatic adenomas are of more concern because most of them are considered premalignant. If they're solitary, they'll often be resected. FNH, unless they get very large, will not be resected. Hepatic adenomas commonly present with spontaneous bleed. In theory, FNH can present with bleed, but that's exceedingly rare. Now, when I mentioned FNH, I said homogeneous enhancement. The lesion will fill in over time and almost become totally isodense. You may see the very edge of the lesion. You may see the scar. The scar may not entirely fill in. And again, as I mentioned, that feeding vessel to the center of the lesion. Most FNHs are solitary, but they can be multiple. With hepatic adenoma, they're vascular. The biggest challenge to me with hepatic adenoma is distinguishing hepatic adenoma from hepatoma. They can be very bright vascular and irregular. because many of them have bled now or before. You see central scars and they look kind of irregular, so you kind of don't know what's really going on. Now, with hepatic adenomas, the bleeding is the number one thing. When we say what lesions bleed, I'll say hepatic adenoma, number one, hepatoma, maybe hemangioma. That's pretty rare. Mets occasionally will bleed. But, again, you're thinking about hepatic adenoma, spontaneous bleed. I don't have a look at anything else. Just you tell me that in the liver, I'm saying hepatic adenoma until proven otherwise. So that's a pretty good way of thinking about things. Now, when you get past hepatic adenoma, again, you worry about hepatoma. Hepatic adenomas will typically be resected. Most of the time, I can distinguish hepatic adenomas from focal nodular hyperplasia. If I can't, MRI can be helpful in that regard. Now, other things that are benign. You can have pseudo lesions like focal fat. Okay, I guess I can consider that a lesion, sort of. You can have abscesses. Abscesses can be cystic, like an amoebic abscess, right lobe of liver. Hydatid disease, where it's cystic with septations, daughter cystic calcifications. Again, certain areas of the world are endemic, but every once in a while we see them in Hopkins as well. So patients travel the world. You never know where they are. So that's a possibility. Abscesses in general, E. coli. Abscesses can look like tumors. Now, often patients have a history. The patient had surgery, appendicitis, diverticulitis. But sometimes the ones that I've gotten wrong, patients are found on the street, let's say, they just no history, they're debilitated, and they have elevated liver functions, they have weight loss, they have fever. Everything that you say about the patient makes me think of malignancy. Then you come across a 5-centimeter liver mass and you say, aha, primary versus metastatic. Now, if it has air bubbles in it, then you're thinking abscess, but less than 20% of abscesses have air bubbles. So you're kind of a little bit in a pickle there. So I do tell people to be careful. When it has this mottled appearance, that's not uncommon for abscesses. And abscesses and tumors are great mimickers. When you have patients with FUO, yes, you're thinking about tumor, yes, you're thinking about abscess, but with an isolated liver process, don't just assume it's a tumor. Think about infection. So that can be very valuable. So that's one of the benign things. We can also think of infarcts. They're kind of wedge-shaped, very much like spleen or kidney. But liver infarcts are rare in the absence of surgery. You're doing a Whipple's procedure, you're doing some sort of hepatic surgery, someone's messing around with the hepatic artery. I can see where you can get hepatic infarcts, but hepatic infarcts are far less common than splenic infarcts and far less common than renal infarcts. So those are the main things I'm thinking about when I'm doing benign lesions. Now, obviously, it's not easy to say this is benign, this is malignant all of the time. And there is this great overlap. I mentioned abscesses, hepatic adenoma versus hepatoma. At times, it can be difficult looking at atypical FNHs. Occasionally, there's an atypical hemangioma. Now, sometimes the hemangioma fills in their entirety right away, flash filling, and you could say, okay, that's a hemangioma, unless the patient has a neuroendocrine tumor. Then you're worried about some overlap there. Typically, that's usually not a problem. But it's not always easy, and that's maybe the point I'll leave you with. I've given you a bunch of rules. This sounds like Moses on Mount Sinai. I've given you a bunch of rules, and you need to live with those rules. You live with those rules, things will be good, but they're not going to be perfect. Every once in a while, a tumor or an abscess or a benign lesion will not follow the rules, and you'll be wrong, or maybe not so much wrong as you may not be right. So again, it's good to be flexible. It's good to be thinking a lot. It's good to be really looking carefully at lesions, but understanding there are exceptions and not every rule is perfect. And with that, not every rule is perfect, I'll stop there. For those of you, I'll just say, I forgot to say it before, of the Jewish faith, the high holidays, Rosh Hashanah, which is this past Monday and Tuesday. The Day of Atonement, Yom Kippur, is next Wednesday. So I wish everybody health and happiness and peace and prosperity. And if you're not Jewish, I wish you happiness, health, good times, and prosperity. I wish everybody the same. I hope this coming year, which begins, we just entered, is a fruitful one for everybody. And with that, I thank everybody for their attention, and I'll see you next week. Have a great day, everybody.